No, when I talked to Jack yesterday, he was making a couple adjustments to the slides. So there's actually something loaded on the UW website. They have a link to this at the Impact Consent page. Even though they've been doing this presentation now for probably 7 months. It's refining it.
I like to dream that dream of getting presentations early. And we're live now to the Harbor View. So.
Can we see them or they just see us?
They just see us. We didn't go to the two-way route because we won't have time between the faculty meeting and the grad round. It's also not us.
Yeah, because we looked at it again. Okay. Did some peer comparison and everything. Actually, it's definitely in line. Still. Yes. We haven't seen it through, so that's been weird. That hasn't been approved yet. So we go back and forth with them the other day. They're just still looking at. Yeah. But they're okay. Right, they perfect tool.
Test. No, I know. I was. Testing, testing.
I believe there will be, because Terry said if we are live, our meetings don't see that message. I think there are.
Aaron, quick question, will parents be able to chime in any questions? No.
Oh, they won't?
Yeah. The downside. Morning, Dr. O'Kane. Yeah, we're going live, so they can hear us.
I'm just going to make a few announcements before Jack Lee starts. My main announcement is about the holiday party. We've done this for many, many years. I will say that I've had a few people in the past few months come up to me and say, why is our party not as nice as the holiday party we had when I was a resident or I was a fellow? I've had other people say, why don't we get together more frequently during the year as an entire department? And I have not had anybody tell me directly, but I've heard that there are people who are sort of feeling like it's not fair that it's a UW medicine-centric party. But I can tell you, we don't have any special invite listed to you. We have not sent out any global emails inviting people. It really is the same for all of the hospitals. We've just said, within reason, invite the people that are important to you. And so the cost is not that great. I don't think it's really not for us. The party is for the people we work with. As somebody put it at the faculty at our vice chair meeting, we're trying to help the people who are, in general paid, 1/10 or less of what we are. And so it's really not about us. And so going forward, we'll consider other ideas. The ideas brought up were maybe to just have a departmental holiday gathering just for our families. It would be less expensive, and then people could take the leftover money from that and contribute to their own hospital functions. My sense is most people want us to do something. They don't want us to disband it. Other people have brought up just going big. I think Chappie organized a huge party at the Mountaineers Club maybe 10, 15 years ago. And I think there were probably about 400 people there, if I recall. But again, that requires buy-in from all the faculty, and the cost of it may go up. So Pamela Halberg has the unenviable task of collecting the money for the party, and I really encourage people to donate for it. So we have Jack Lee here this morning. Jack is a professor of mathematics, and he also happens to be chair of the Faculty Senate. And I know all of us have heard rumors and seen sort of dribbles of data over the last 6 or 7 months about how our system for getting merit raises and rank raises as we get promoted may be revised. And I'll ask my main question in advance. It looks like when you look at the data, there are not going to be great changes in sort of overall pay, overall raises. And so my question that you can answer as you go along is, what are the benefits of this system that seems a little more cumbersome and complicated, and in the end may not result in significant differences in pay?
I will be happy to answer that towards the end. First, I should say I am I was last year the chair of the Faculty Senate. This year I'm chair of the Senate Committee on Planning and Budgeting. So what do you call it? The swan song of faculty leadership after 2 years in Senate. You become chair of the Senate Committee on Planning and Budgeting. So,
Speaking into the mic. As we're going to Harvard and it's hard to hear.
all right. So this mic here?
Yeah.
Is this okay? So I just want to start with why are we doing this and what prompted this? This project started about 2.5 years ago. The president commissioned a joint working group of faculty and administrators. I won't show you the list that's available online. By the way, at the very end of this, I will give you a link where you can find a lot more information and contact information where you can contact us if you have questions or suggestions about the policy. So I think a good place to start is the salary policy that we work under now, the 2% regular merit, the variable amount of additional merit, was created in 2000. And there's this nice little quote in the presidential order that implemented the salary policy, which is, as you see, the fundamental purpose is to allow the university to recruit and retain the best faculty. So how did that work? If you look at a snapshot of salaries, this is actually last academic year, 2012, 2013, but it hasn't changed very much. A snapshot of salaries plotted against time since terminal degree across the entire university. What you see is the green line is our peers, the Global Challenge State peers, and the red line is UW. So as I say, this is a snapshot, but you can also think of it as a rough idea of the salary progression of an average individual adjusted for inflation. And what you see is at peers, people rise pretty fast in the early full professor years when people typically are most productive, and then kind of levels off at the end of a career. And at the end, the average retiring full professor is making about twice as much as the average new assistant professor. At UW, we hire in at market rates, in fact, a little better than market rates on average, but then we very quickly level off, and the ratio of the average retiring professor to average new assistant is a little more than 1.5 to 1. So that's the basic problem from an overall university point of view. Now, the profiles in different colleges, different departments are going to look different from that. Some departments are actually doing pretty well, and yours might be one of them. I don't have as detailed data about the medical school as I have about upper campus, but there are some departments whose red curve is much closer to the green one. What you see behind this red curve is, by and large, people have been governed by the standard processes of the current salary policy. That is, everybody who's meritorious gets a 2% raise. Everybody who's meritorious might get a little more if there is more. Last year, it was 2% plus 2%, for example. People who followed that standard raise allocation basically are flat, because that comes out to something like 3% a year on average over the last 30 years. Meanwhile, the entering salaries have been going up at about 3%, actually more like 4% a year. So if you just get raises according to the standard provisions in our current salary policy, you are basically falling behind the new assistant professors. The only way that this red curve is as high as it is because a lot of people have gotten retention raises. And I think in the School of Medicine, it's much more common than upper campus. People manage to get reasonably competitive salaries, but only because there are a lot of preemptive retention raises and some retention raises in response to actual outside offers. So this is not the way the system was meant to work. It gives lots of retention raises. People who don't get the retention raises fall farther and farther behind. There's a lot of resentment, and many faculty feel that just working your ass off for the University of Washington and being excellent here is not adequately rewarded. So that's basically the problem we're trying to solve. We sort of took this initial statement of purpose and decided we needed to revise it a little bit in order to recruit and retain the best faculty. We feel we have to motivate and reward excellence among people who are here. And so the purpose of what we're trying to do is to create structural pressures that will provide more reliable career salary progression for continuing faculty without having to rely on retention raises. That's the basic starting point. So we took that, we thought about a lot of different ways we might do that, but what we came up with was this following proposal. It has 4 parts. I'll go through them quickly and then I'll say a little bit more about each one. The first is rank promotion raises. That's a provision in the current salary policy that works pretty well. You get a 7.5% raise if you get promoted from assistant to associate or associate to full. We want to continue those but make them bigger because they're not enough as they stand, so they go up to 12%. The second part is tiers, which I will talk a lot more about. That's really the heart of the proposal here, the tier system. And then there are these other 2 parts that are meant to sort of bring the whole system along with the market, with our competitors. Market adjustments based on CPI and variable adjustments which are variable. So rank promotion raises, there's not much to say about. The 7.5% was good, but not enough to reproduce that green salary curve. So we're raising that to 12. What about the tiers? The idea is we want predictable raises for excellent continuing faculty, but we want them to be based on performance. We don't want to set up a system where anybody automatically gets a raise, whether it's every year or every 4 years or whatever. If it's going to be based on performance, we feel very strongly that the performance evaluation has to be done, at least in the initial stage, has to be done by faculty colleagues. Now, we have a system now that's supposed to do that. Our current salary policy says everybody gets a merit review every year by their colleagues, and that merit review is supposed to determine the size of your raise. Typically, if anything, it will determine whether you get 3% or 3.25% or 3.5%. Because those reviews come with such little reward, and because they're so frequent every year, a lot of departments, a lot of colleges just don't take them very seriously. You may be one of them, I don't know. So what happens is there isn't really an effective system of collegial review, and there isn't an effective system of reliable reward for people who are doing well. So we wanted the evaluation of performance to be done by faculty. We didn't, if we're going to try to make it more serious, we really don't think it needs to happen every year. And so we wanted to back off from the requirement of annual reviews, change that to reviews approximately every 4 years. These are supposed to be done by colleagues. What we think will happen is there will be a committee of faculty, probably with the chair involved. It's really up to the department how to structure it. The committee will look through the people who are up for a tier advancement this year, and maybe some others for early tier advancement if somebody thinks that they should be eligible. That committee will make recommendations to the department will vote, and the vote can be either recommendation for tier advancement now, or in appropriate cases, maybe initiate the process for promotion, which will then go ahead as it does now, or maybe a finding of unsatisfactory performance, which will have salary consequences, or maybe none of the above. You're doing fine, but it's not time for a tier advancement. Maybe your productivity's been a little low. You should wait till the 5th year or the 6th year. Come back again and talk to us next year. So that's the basic structure. The tier advancements will come with fairly big raises. Now, I need to say a little bit about the formula for these raises. We started with the idea of 8% tier raises. So that would be, on average, every 4 years, continuing faculty would get an 8% raise. We quickly realized that, for one thing, if you look at what that does to the career salary progression, instead of that green curve that we saw that rises and then levels off, 8% every 4 years is exponential growth. And so we would be creating a salary profile over time that just goes up and up and up more steeply. And we were afraid that would just pump way too much of our resources into the most senior and highest paid faculty members. So we wanted a way to get that curve to level off at the end of a career. That was one thing we had to change about the 8%. The other thing is, when we look at the most highly paid departments, by and large, for example, we spent a lot of time with the business school. In the business school, the typical hiring in salary is about twice the UW average. Makes sense, that's what they've got to do to be competitive. But if you look at the profile of peers, it rises less than half as fast as salaries in the rest of the university. So in the business school, even 8% every 4 years for the first half of a career would drive salaries way beyond peers. And we didn't want to create a system that was going to force any college or any department to break its bank just to fund these raises. So here's what we came up with, this formula where everybody whose salary is below the UW average gets an 8% raise when they get a tier advancement. Everybody whose salary is above that number gets 8% of that. So what that means for people, I would guess most of you are probably on 12-month contracts. So on 12-month contracts, the UW average is currently about 166,000. And so if your salary is above that, your tier raise would be 13,333. Now, this is changeable. This is our proposed formula, which seems to work for a lot of departments in a lot of different economic circumstances, but there's a provision in our proposal to allow a department or an entire college, with the provost's permission, to change the formula. If this formula doesn't work, for example, if orthopedic surgeons need to have 10% raises every 4 years to keep up with their peers, and you can afford it, then you can propose that change, and as long as it's justified by market conditions, there's no reason why the provost wouldn't approve. But you don't have to do that. There are other flexibilities built into the system that will allow you to keep up with market. So that's the basic structure of tiers. I can take questions now, but let me just go through and finish, and then we'll have plenty of time for questions at the end. So the third and fourth pieces are meant to track the fact that at our peers, and at UW historically, not only do people move up along the curve as they get more senior, but the whole curve rises with inflation. And so we need a piece of the system that's going to bring up all salaries at all levels at something like inflation, or we'll be falling farther and farther behind peers. So the first part of that is the market adjustment. It's based on the the CPI, Consumer Price Index. Over the last 30 years, that's averaged about 3% a year. Currently, it's a little under 2, somewhere between 1.5 and 2. So that means everybody, except those who were determined non-satisfactory, gets a 2% roughly raise. So this kind of replaces the 2% in the old system. But this is going to be more effective at keeping up with market salaries because it's tied to the CPI. The 2% was not sensitive to changes in the economy, which is one of the reasons why the system collapsed in the recession. And then the last part is variable adjustments. Even pushing our salaries up at the rate of CPI inflation still doesn't keep up with peers, because peer salaries have been going up about 1% faster than CPI for as long as anybody can get data. As have the UWs, by the way. This is not changing the overall amount of money that needs to be pumped into the salary system. UW salaries started much lower than peers 30 years ago. Both peers and UW went up about 1% faster than inflation, and so we ended up behind peers at about the same ratio. We've got to make sure that we can at least continue doing that, or we will fall farther behind. So the variable adjustment piece, we figure, will probably average out to about that extra 1% that's needed to keep the overall levels up with peers. But it's very flexible. So for example, if in orthopedics you find that the tier raises aren't large enough, you can just use this variable adjustment category to augment them when you have the money. You can use it to address compression issues, to address equity issues, whatever you need. The only restriction on it, really, in the code will be that the voting faculty of the unit have to approve the procedure, have to approve the principles for how it's distributed. So basically what we think is the current system is a straitjacket, which basically gives you only retention raises as a tool to try to keep up with market, and leaves a lot of people behind. This system is going to be more flexible. The only place where it's less flexible is it's going to have pressures to put more of our available resources into continuing faculty raises because of the two parts of the system that are mandated, the market adjustments, CPI-based market adjustments, and the tier raises. Those two parts are mandated. You've got to find the resources from somewhere to fund those, and so we think that in a small way that will tip the balance when priority decisions are made to put more money into raises for continuing faculty. So that's a basic picture. I've listed a few of the advantages here. First one, but we want to motivate and reward outstanding performance throughout a career. Right now, faculty members get 2 promotions in an entire career, and we want basically more opportunities to demonstrate excellence and be rewarded for it, and be rewarded in a significant way. As I mentioned, we want to replace annual merit reviews with these 4-year reviews. We want to give units more flexibility to appropriately reward excellence. More than almost anything else, we want to reduce the reliance on retention raises, and especially preemptive retentions. We think under this system, basically preemptive retention raises can go away and instead can be folded into the tier system, maybe augmented with variable adjustments. Retention raises in response to outside offers, they're going to continue to happen, and there's no change there's no restriction on those. We've done a lot of modeling. We've done modeling of the university as a whole. Ruth Mahan in the medical school has done modeling of a couple departments in the medical school. This is basically just as affordable as the system we've been running on. In tight times, it will force some hard decisions to put more resources into continuing salaries, which will probably, if things are really bad, we're not getting extra money from the legislature, it will cause some pain somewhere else. But that's our goal. We really want to put a thumb on the scale so that the system is structurally set up to put pressure on units to put a little more money into continuing faculty salaries. And we think over the long run it will make the UW more competitive by not only making our salaries closer to those of peers, but enabling us to tell new faculty members that we're trying to recruit that you can look forward to a reliable salary growth over your career if you do good work. So I want to also mention some of the possible objections. People worry that the collegial reviews are going to be more work, and certainly in departments that are not currently doing the annual merit reviews that the code calls for, this probably will be a little more work. The bottom line is, if we believe, and we in the Senate leadership certainly do, and most faculty members I've talked to do, if we believe that salary raises should be based on merit, on performance, and if we believe that that performance should be judged by colleagues, not by chairs and deans, then something like this has to happen. And by making it not have to happen every year for everybody, we feel that the workload is reasonable and it's worth it. Another possible objection is that basically what's already been asked, that if the funding is really tight, this won't be able to make a big dent in the compression problem and the salary gap. And if the funding is really tight, the effect of this is mainly going to be, as I was saying before, on this pressure in making priority decisions. It's not going to make a huge difference in our salaries, but it will ensure that a decent career salary approach is the first thing that has to be funded. It might mean cutting back on something else. In my department, it might be cutting back on TA positions. It might mean making the faculty smaller. It might mean delaying new buildings or new programs. It's up to each unit to decide how to make those priority decisions. But we think it will have a good effect even under those circumstances. And when there's more money available, it will have a much bigger effect because it will release the straitjacket of the current system. Some departments feel they're doing a pretty good job with retention raises. Our answer to that is we would rather see faculty making those judgments about merit and about salary rather than deans and chairs deciding, okay, this person needs a retention raise. It will put some pressure on grants. That's, again, the priority issue. The tier raises, some departments worry that the tier raises aren't large enough in really highly paid departments, but As I said, they can be changed. And finally, people worry that these mandated raises might draw too much money away from other priorities. Again, it's a priority decision. Do we think that fixing our salary problems is the highest priority for making the university competitive? If we do, we need something like this, and we haven't seen anything better. So, there's the website where you can read the details. There's an email where you can send questions or comments. Also on that website, you will find a discussion board where you can post questions and read other people's answers and questions. You will also find a little spreadsheet that you can use to model what salaries in your department might look like after this system is in effect for a long time. Questions?
How does this tier system change from the tier system in California?
Okay, we did actually start with that in mind as a model. The biggest problem with the California tier system, they call them steps, is that every step, Professor 3 comes with a set salary across the entire UC system. So I don't know the right number, but it may be that in this California system, Professor 3 has a salary of $120,000 a year. Obviously, that's unworkable in a situation where different departments have very different peers that they're competing with. It's unworkable across different schools. And so what has happened is that many people, at Berkeley, almost everybody, get supplements that put them off the salary scale, and their step system is creaking along because it's too inflexible. So we thought about various different ways of doing it, maybe have a range of salaries associated with steps. We finally decided that the best thing to do is to just untether the tiers from actual salaries. So the tier advancements are based on percentage raises, not based on actual salaries. And we think that that will be a lot more flexible and a lot more appropriate to our system. Yes. Well, this proposal is basically moot on the issue of funding sources. Under ABB, funding sources are managed by colleges. In this college, I understand they're basically managed by departments. And the salary policy mandates at minimum what raises must be given to continuing faculty. Where the money comes from is going to have to be determined at the college and department level. So again, with grants, like everything else, it's going to force some changes in priority decisions. Now, let me put a caveat on that. If you're in a department where your salaries are pretty equal with peers, if your red curve closely tracks the green curve, then this is not going to force any more spending on salaries. In fact, the mandated amount will be less than what you've already been spending. If you have been raising salaries enough to keep up with your peers, then you've already been finding enough to easily fund this new system. 8% sounds like a lot, but when you average it out over 4 years, it's actually less than 2%. In highly paid departments, it's even less than that. You add to that the CPI adjustment, which currently is less than 2%. It's not any more than what we've been doing the last couple of years and what we did over the previous 30 years. So yes, we think that grant proposals, over time, people will start building in the expected tier raises into the grant proposals. But if the grant falls short, as now, then you've got to figure out how to deal with that. It's not really any different from the situation we're in now. I know when Ruth Mahan did her modeling, she did one basic science department, which I think was heavily grant funded, and another clinical department, which was heavily clinically funded. And her conclusion was it is just as affordable as the system we're in now.
Yeah, my understanding is that most of the funding for the clinical part actually comes out of UWP, which Washington.
This applies to our component, the component of our salary that also comes from UWP. So it's going to be both our UW and our UWP contribution.
Applies to the full base salary. I guess there's also, what is it, the Z component, which is sort of temporary bonus based. It wouldn't apply to that, but the base salary,
It applies to our X and Y.
X and Y, yeah.
In Ruth Mahan's model, I mean, for the clinical departments, it's, you know, it doesn't change the absolute dollar amount that much. It's a pretty tight range compared to what we do now.
Okay. So, you will all, if this passes the Senate, we hope that it will be voted on by the Senate in the spring quarter. It has to pass the Senate twice. If it does, then you'll all be asked to vote on it. I'd be curious to see, just based on what you know now, if you were asked to vote right now, how many people think you would likely vote for it? How many think you would likely vote against it? Wow, good, good. I do think the advantages for, if you're in a department where your salaries are pretty close to peers, the advantages for you will be somewhat less than they will be for a department like me where we're 20% behind our peers, especially at the senior level. But I still think there are advantages, and I think for almost every department in the School of Medicine, there will be advantages, just for no other reason than that the raises will be much more rationally based on peer evaluations rather than the sort of randomness of preemptive retentions that seems to prevail now. Thank you. I can stay around for a few minutes if anybody wants to ask.
Well, our grand rounds actually has to start for us to stay on time. Does anybody have any more quick questions? And we can email
Yes.
at that address.
Yep, and you can, yeah.
Thank you.
Thank you. Did I get one? Stick that down. Aaron's
Is this it right here? No, that's actually, no, that's not it. Good morning, everybody. A couple of quick announcements. I think everybody's here. We have quite a few people watching remotely from Harborview. First matter is our new Chief of Pediatric Orthopedics at Children's. I did see her in the room. This is Suzanne Yandow. Welcome. And I also wanted to take a minute. We're going to have lots of sort of formal events. Chappie's not going anywhere, but whether he likes it or not, we are going to honor all the great things that he did at Children's over the last 10 years or so. And just to remind everybody, Children's is on a great financial footing in our department. Chappie, I think, at least doubled the size of the department. He had the foresight to sort of realize, I think, where musculoskeletal care was going, and he brought lots of colleagues outside of orthopedics into the department, and I believe Tom Jinguji, who was here this morning, I think was brought into orthopedics by Chappie, and other pediatricians. And one of the residents said to me yesterday that Children's for a long time has been a happy place. They love their rotation there, and it hasn't always been like that. So I want to thank Chappie for everything he's done there, and he's going to stick around, and I'm going to continue to pester him for advice on all sorts of things. So thank you. This morning, our grand rounds is on sports concussions, and we are fortunate to have John O'Kane here, who everybody knows, still a member of our department, but now in family medicine, and Stan Herring, who also everybody knows, and Stan, I think people know, works with the NFL on this huge problem, and then Tom. And Emily Harden is the resident who's going to run it. So.
Okay. So good morning, everyone. Thanks for coming this morning. We have a lot to talk about. So I have the privilege of introducing our talk today on sports concussions. I'm going to start off with an overview of what concussions are, to provide a foundation for the rest of our talk today, and then I'll hand it over to our guest speakers who are going to talk a little bit more about assessment, management, legislation, and then long-term concerns of concussions. So here are disclosures. So I'm going to start off with a case study to hopefully emphasize some of the key points that we hope to convey today. So particularly for the residents, imagine that you're in your first year out of sports medicine fellowship, and you're new to your community and you want to get more involved, so you decide to sign up to be the sports physician for your high school team. You're at your first girls' soccer game, you're standing on the sideline, and this happens. A 17-year-old player struck in the head by the shoulder of a defender. She falls to the ground. She has no apparent loss of consciousness, but she doesn't get up right away. So you're standing on the sideline. What differential diagnosis is going through your head at this point? So if you're paying attention to the title today, you're probably thinking the first thing that's happened is potentially a concussion. And at this point, if you're thinking about that, what do you do next? So to answer these questions, it's important to know exactly what a concussion is. So to simplify it, a concussion is a brain injury, usually due to biomechanical forces, that sometimes results in transient disturbance of neurologic function, but it's not always transient. It happens from an indirect or direct blow to the head, such as this here or this here. And importantly, with sports concussions, it rarely involves loss of consciousness. So this only happens less than 10% of the time. So if there is a loss of consciousness, you should be thinking about something else. Concussions are common. They occur there's about 1.6 to 3.8 million sports-related concussions each year. This number, importantly, only comes from recreational athletes. This doesn't include collegiate or professional level athletes. And it's likely an underestimate as well because injuries are often unrecognized and not reported. The incidence is increasing, although this may be a result of increased awareness and therefore more reporting of concussions. as there hasn't been an increase in incidence of more severe traumatic brain injuries in the same time period. And the outcome is generally favorable most of the time, but it's common enough that sometimes the outcome isn't favorable, and concussions may have lasting effects beyond the immediate concussion symptoms, and occasionally concussions can be catastrophic. And this is what we often hear about in the media, as shown by headlines such as these. And later on in our talk, we'll hear about a local case that had a similar catastrophic outcome and has since gone on to influence a lot of concussion legislation, as well as how we manage concussions today. So stay tuned for that. The pathophysiology of concussions is pretty complex, but hopefully I can simplify it for all of our understanding in our talk today. After a traumatic blow to the brain, the neurons have a mechanical disruption that results in membrane stretch and axon stretch. This ultimately leads to release of excitatory neurotransmitters like glutamate, and this causes a membrane imbalance. Particularly, there's a calcium influx and a potassium efflux. And as a result, the energy stores of the cell are stressed, trying to restore homeostasis. And eventually this results in a complete dysfunction of the metabolic pathways of the cell and altered cerebral blood flow. And the end result is an energy crisis. This energy crisis makes the brain more vulnerable to injury and makes the brain a lot less functional. So as it's trying to repair itself, it's more vulnerable to another injury such as a second concussion. So back to our case with those things in mind. So your athlete's able to get off the field with some assistance from you. When you get back on the sideline, she tells you she has a mild headache, and her next question is when she can go back to playing the game today. So another question to think about, do you think she can return to the game today, and can you make that decision right now? And if you think she's had a concussion, how do you know for sure? So the signs and symptoms of concussion are numerous. They're typically divided into 4 different categories: physical, cognitive, emotional, and sleep. And the important point about this slide is that concussion symptoms are nonspecific. About 60% of college athletes report concussion-like symptoms with no history of head injury, and up to 85% of high school athletes report concussion symptoms at baseline testing without any history of head injury. Concussion symptoms are variable. They can vary between different athletes, and in an athlete that's had multiple concussions, they can vary from concussion to concussion. So that makes the diagnosis difficult, and that's why it's important to standardize the diagnosis so we can figure out exactly who's having a concussion and who isn't. The most common presenting symptom is a headache that occurs in about 90% of patients, and the second most commonly reported symptom is dizziness. So back to our case. So once you suspect a concussion in your athlete, how should you evaluate her, and what diagnostic tools do you have to do so? If you decide she's had a concussion or not, what are you going to do after you've completed your assessment? And if you decide that she needs to be sidelined, how long does she need to stay out of the game? Can she go back that day, the next day, or does she have to wait for a couple of weeks? So to help us answer these questions, I'll turn it over to Dr. Jinguji, who does this a lot more than we do.
Emily, thank you. Thank you so much, Emily. So my name's Tom Jinguji. I'm a sports doc over at Seattle Children's. It's nice to be able to talk with you. I appreciate, Emily, all your work, because in case you don't guys know, I'm the guy. Emily had to take care of me because I'm the guy that always gets his slides in late and has to make all the changes. So thank you. So we're going to talk about initial management of concussion, and really not just management, but counseling. And the reason I say this is because many of you might be on the sidelines, but many of you aren't. But at the same time, you might need to know this stuff, or it's nice to know this stuff, really, because if you're at your daughter's soccer game or your niece's soccer game and something happens, it's not as though you might take a step forward, but everybody else takes 3 steps back, and then they kind of look at you and say, well, what do we do now? And just having some knowledge of that, even to manage it, is very important. So these are some of the questions I'd love us to be able to answer after I get done speaking. 1, what do you say if someone asks about an athlete with a possible concussion? Which kids or athletes get held out of play? And I'm going to talk about really high school athletes and middle school athletes. The college athletes and the NFL guys are for other people. We're talking later. What do you tell them about when to go back to sports? And if you actually do have to be on the sidelines, what do you do? Or what do I do? And I'll try to tell you that. We'll try to do this fairly quickly, too. So Emily did this perfectly. She defined concussion. This isn't how to diagnose it, but we have a definition. It's a brain injury. It's a direct blow, a physical force acting on the brain, usually short-lived things that usually resolve. So this is, things do, in general, very well with concussions, but this is acute. There's symptoms. There's a major thing, and it's a functional disturbance, not a structural injury. So neuroimaging studies are typically normal. So if we're trying to diagnose concussion, CT and MRI are going to be normal for what we normally talk about. So it doesn't help us in this realm. Another way that we define concussion, and this really isn't a definition, this is really almost more like a threshold to act. Dr. O'Kane and Dr. Harden are going to be talking much more about this, but we have a law in Washington named after a child who was severely injured, catastrophically injured, the Lystat law. This is the first law of its kind. But this requires removal from play or practice of any youth suspected of sustaining a concussion or head injury. So even if you're suspecting something, we're going to take them out. Now all 50 states have similar laws. Because we used to say, you might do it different here, but now everybody has a very similar law to this, thanks to some work that was done by folks that you'll meet later. Sideline decisions are very straightforward now. They're not easy, but they're very straightforward. So any kid, this is one of our mantras, if you have a kid with a concussion, we sit them out. So they're done for the day. Or any concern for concussion. Okay. So if a player shows any features of concussion, they should be looked at by a physician, or usually we call it a qualified healthcare professional. And then a player with suspected concussion should not be allowed to return to play on the same day. So again, this answers two questions. If you think it's a concussion, we take them out. The next thing is, well, 10 minutes later, they might say, I feel great, can I go back in? If you've made a decision that it's a concussion, the safest thing to do, and really the only thing to do, in our opinion, is to keep them out for that day. You're done for the day. Okay, so the next question is, when do you go back? When can they go back? Okay, in general, we never return athletes to play until they are back to their baseline. Many, many people have symptoms, concussion symptoms. I feel dizzy, I have a headache, I'm tired. All of you guys probably feel that way right now hearing me talk. So hopefully you don't have concussions, because I don't want you to go and do great things later on and surgeries. But anyway, so many, many folks, hang on, getting backed up here. Here we go. So we don't return them until they are back to their baseline, symptom-free from the concussion. Once back to baseline, we use a gradual return to play process. It takes, you rest them, and then we have them doing some jogging after that, light aerobic activity, sport-specific exercise. This would be things like shooting baskets or doing some drills. Non-contact practice, full contact training. Each of these steps is a day or more, and then return to full games. So the quickest for us, if you have a concussion and you feel great, Friday you have a concussion, Saturday or Sunday, you're feeling well, we're going to go through these steps, and it takes about a week to get back. So that's your Thanksgiving Day question. When can my niece come back to play? You're going to be symptom-free, and then you're going to wait, slowly going through 4 or 5 days or 6 days of slowly advancing. Okay. Why are we doing this? We could spend 6 hours talking about why, but I think quickly, one of the things we're trying to do to avoid brain injury and repeat brain injury, particularly when you're having symptoms, we want to wait until you're symptom-free before you get your next brain injury. We want to wait. We're trying to eliminate the risk of catastrophic brain injury, something that we see in kids that we worry about called second impact syndrome. Second impact syndrome, where kids could get a repeat injury from the first and have catastrophic problems. We decrease risk for prolonged symptoms for the concussion too. Because remember, if somebody has concussions for 4 to 6 weeks, they're not just out from sports, they're also out from other activities. The biggest activity they have is school. So every kid that I see is also a student. So repeat concussions can make things last a lot longer. Okay. So now if you actually do have to manage concussions, here's some things we're going to talk about. Hopefully we'll spend just a moment on this. We'd like that you have a plan going in. ATC, EAP, let's talk about some chicken noodle. We'll talk about some letters. Okay, ATC. What is an ATC? It's a certified athletic trainer. If you're out there in your fellowship or done with your fellowship and you have to decide which school should I go to try to help out, it's going to be a lot easier if you have an ATC with you. Athletic trainers know about concussions. They're the ones that manage things. Having two people out there, one to manage a concussion and one to watch the sidelines, is very helpful. It's really, really nice. And all the other things come into play if you have an ATC helping you. If you don't have an ATC, the next alphabet soup thing we're going to talk about is something called an EAP. That stands for Emergency Activation Plan. This is what do you do if. So if there is some type of horrible neck injury, thinking about what will you do before it actually happens is vital. Where's your spine board at? Who's going to call 911? Where does the ambulance go? All of these things are written down in an EAP if you have one. If you don't, trying to remember those steps would be very, very important. And getting it done before you get there, before you're trying to manage things on the field. Next thing, these are tough decisions because you've got a very stressful environment. You've got family often around, and some family is going to be just so distraught that their child has a possible brain injury. They're going to be trying to call 911 and having airlift come. Other times, you're going to have families who come in and they're going to actually pressure you to say, why don't you get this kid back in? He's fine. He does this every week. And trying to have a systematic plan on how to do this is very important. And a great resource for all this stuff that we talked about today is the Zurich 2012 Consensus Statement on Concussion. And it's really hard to get to. You want to go to Google and look up Zurich 2012 Concussion, and it'll all be there. On-field management, I think you guys already know this one. Airway, breathing, and circulation. We're going to make certain his C-spine and his brain is doing, her C-spine and brain are doing well. And if things are concerning, C-spine, backboard, and we get them to the ER. And that's the part of that EAP we're talking about. For our 17-year-old girl, she's able to walk to the sidelines. She wants her to get back to play. She might have a headache and feel dizzy. So this one we can keep going. This one doesn't need to do all this stuff. So now we're finally going to get to kind of how we actually diagnose concussion. Okay? So we know that it's an acute event. It's an injury to the brain followed by altered brain function. There are many domains affected. We talk about symptoms. We want to make sure, we want to evaluate for physical signs, behavioral changes, cognitive impairment. Sleep is an interesting thing. This is one of the domains. We're not going to be able to identify this one as much immediately, but later on, this is one of the things. We're going to look at all these different things with a standardized concussion assessment tool. So we're going to try to do something. We're going to do it very systematically. We're going to look at symptoms, orientation, memory, balance, and concentration. This takes about 8 minutes to do, and one of the tools that we use, probably the most common, is something called the Sports Concussion Assessment Tool. And this is actually also within the Zurich Concussion 2012 statement. It's got a funny acronym, SCAT, and it's the third iteration of this. But it talks about, we look at 22 symptoms. We go over score, orientation, what day is it, what's the score of the game. We look at immediate and delayed memory. We look at concentration. Simple things, taking the months of the year, looking at things like just doing sequencing numbers, things that they should be able to do, but sometimes with a concussion they often can't. And we also look at balance. And balance is these 5 things taken together. It really helps to sort out if the child has a concussion or not. It really helps with our diagnosis. Because again, CTs and MRIs aren't helpful. It's really a clinical diagnosis. And doing this each time is nice. Get going. So if we have a child with a concussion, we're going to remove them from play. We're going to take a helmet away. We're going to try to have serial check-ins with repeat evaluations. And we're going to decide if they're going to go home or to the emergency room. So when we send somebody home, we're going to make certain that they're monitored by a family or friend. We're going to give them good instructions. One of the instructions that the neurosurgeons really like to talk about is vomiting. If a child has vomiting within two or three times or more during that first 24, 40 hours, that's a big deal. Those kids, if you hear about that, those kids should go to the ED for a CT, looking for some kind of intracranial injury that's progressive. Okay. So here's our case. How should she be evaluated on the sideline? With a systematic review of looking at all those different areas. And we hopefully can define a concussion. Hang on. What's going on with her disposition after you've completed your assessment? ED, watching her, serial assessment, making sure she's fine. How long does she need to be on the sidelines? That day for sure. She doesn't go back. Okay. So I'm almost done here. So let's go over these questions again. What do you say if someone asks about an athlete with a possible concussion? Which kids get held out of play? I think, in general, the safest action is to remove any athlete from play if there is concern that he may have suffered a concussion, that she may have suffered a concussion. Next question. What do you tell them about when to go back to sports? Athletes, not just with concussion, but concern for concussion, should not return to play on the same day. They should not return until symptom-free or back to their baseline prior to concussion. Once they're back, they utilize a gradual return to play. And last thing, if you have to be on the sideline, have a plan, know what you're going to do before you're going to do it. Use a systematic evaluation to define concussion. And the last thing is be definitive. If somebody's done, in your opinion, they're done. Don't hem and haw. Don't say, I think we can go back. Just have them done for that day. So thank you. I'm going to turn it over to John.
This is like tag team wrestling. I'm the next guy up, coming off the ropes. And the past couple of years, I've been teaching the AAOS board review course, and that stuff that Dr. Jinguji just went over is actually on the test. That's the part that is guaranteed to be there. The next two sections are a little more for interest and entertainment. What I wanted to touch on is concussion legislation for a couple different reasons. There aren't too many areas of medicine where we practice where there actually is legislation that gets involved in what we're doing and how we're doing it. And also because Washington really led the charge in this area. This is my daughter in the blue, surrounded by crazy white. And so this is kind of, this hits close to home for me. So what is the problem? The problem with concussion, and Tom alluded to it, is that the coaches and the parents and the kids don't really appreciate the significance of concussion and what it means. The other problem is that kids may not know what concussion symptoms are, but even if they do, they don't often report them. And then as well, if you're observing a game, it's not really clear if someone is or is not concussed. So you can look at someone and appreciate that their forearm is fractured, but you can't really necessarily appreciate that someone's concussed. And then also, particularly with kids, while it's not common, there's some really uniquely bad things that can happen to concussed kids if they keep playing. And Tom alluded to that as well, second impact syndrome, which is rare, but it's catastrophic. And so it's really important with kids that we're clear on, clear on what could be a concussion and we get those kids out. So one solution to this problem that's been proposed is concussion legislation. Right now, all 50 states have some form of concussion legislation. So no matter where you go practice, there are laws in place about managing this problem. Most are modeled after the Washington State Zachary Lystead law, and it was the first of its kind that was passed in 2009. So what the law says is that all parents and players have to annually sign a concussion information sheet. Anyone, they have to agree to remove from participation anyone suspected of having a concussion. And then before you can return to play, you have to have written authorization from what Washington calls a qualified healthcare professional, or a QHP. And that is a physician, a nurse practitioner, a physician's assistant, or a certified athletic trainer. So that's the law as it was put in place in 2009. So we actually have some research that looks at how this law has worked in Washington, and a number of the people here have been involved in that research. And we were fortunate because we happened to be doing a soccer injury study between 2008 and 2012. So this law landed kind of right in the middle of the study, and we were following concussions and concussion management. So we got a look at sort of what kids were doing before and after the law was passed. So we were following 12 to 15-year-old female soccer players, and weekly we were assessing them for symptoms of concussion. And this is the only slide that kind of has data on it. But essentially what we found is that before the law, about 70% of players were playing despite the fact that they were reporting concussion symptoms. After the law, that number dropped to 56%. That was not a significant change. The numbers were small, particularly on the front end of the law. The other thing, so there may have been a trend toward playing with symptoms, but it wasn't quite, toward fewer people playing with symptoms, but it didn't reach statistical significance. What's interesting is that this next question, were you ever evaluated by a healthcare professional? In this group, it didn't change. About 44%, a little less than half of the folks reporting concussion symptoms were seeing a healthcare professional. But if they did see a healthcare professional, the healthcare professional was more likely to diagnose concussion after the law. So that went from 40% to 86%. So the law definitely affected the healthcare providers. It's not clear how well it affected the players and the coaches and the parents. What did determine whether or not somebody saw a healthcare provider was how long they were symptomatic. So if the kid had concussion symptoms but they resolved within 2 days, they were unlikely to see anybody. If they had symptoms that tended to last for more than a week, they were much more likely to see somebody. And that just makes sense. I mean, if you think about it, I could go 3 days without ever seeing my kid right now. So whether or not she had concussion symptoms might not be clear to me. Again, the law states that anyone that develops these symptoms needs to be evaluated. But in fact, it seems to be really the length of symptoms right now that more drives that evaluation. One thing that is good to see is that those who were evaluated were less likely to play with their symptoms. So if you can get these kids to see us and we can give them the right advice, then they're more likely to do what they're supposed to do. So in summary, the concussion legislation, our initial kind of look at this, it was effective in that fewer played with the symptoms after the law. It appeared that it was going that direction. After the law, the healthcare providers were more likely to diagnose a concussion. And if that evaluation occurs, they are definitely less likely to play with symptoms. What's not reassuring yet is that we still had over half of those players playing with symptoms despite the passage of the law, and the law had no effect on the percentage that were evaluated by the QHP. So there's been some other studies that have looked at this as well. And one question is, education is part of this law. And so one question is, does educating kids about concussion help? If you tell them about concussion, if they learn about it, are they more likely to not play? And what's interesting is they say that that's the case. If they've had prior concussion education, 72% said that they would notify a coach and not play if they had these symptoms. If you don't educate them, only 36% say yes. So educating the kids, at least they say that once they've received education that they're going to do the right thing. And the other thing that's reassuring is that if you look at high schools, after the law, the rate of concussions actually doubles. It goes from 1% to above 2%. And I don't actually think that's an increase in the number of concussions. I think, as Tom was saying, that's an increase in awareness. So I think there's pretty good evidence that having a law in place reaches the ATCs. It reaches everybody involved to the extent to which that you start to get more people diagnosed with concussion, which is good. Another part of the law was concussion education, and that's another place where the law has really worked well. This was a survey that looked at both soccer and football coaches 3 years after the law, and nearly all of the coaches had received concussion education by 2 different modalities. So there was really an investment in getting these coaches educated about concussion after the passage of this law. The athletes, only a little more than a third had education through 2 modalities, and about a third remembered signing the piece of paper. Parents were the least educated. It sounds familiar. Parents were the least educated, but more than half of them did remember that they did have to sign a form. What's interesting is that football coaches were twice as likely to be educated compared to soccer coaches, and the football coaches were also twice as likely to actually take that education to their athletes. So I think in football, and Dr. Herring will touch on this, I think football coaches are very aware of this issue because it's really in the media. I think it's important that we get this education out to not just football, but other sports as well. So did the education component reach beyond high school? So this is a good question. The Lysted Law specifically applies to high school athletes, but anyone who uses the high school fields are subject to the law. So youth soccer is subject to this law as well. So this was a questionnaire that was addressed to youth soccer players, and after the law was passed, almost all of the youth soccer players could identify what concussion symptoms were, and 90% said they would not play with symptoms. So this sounds really reassuring. 85% knew about the law, and 73% knew that they had to get written clearance to go back to play. But, and this is one of the more recent studies, and this one actually confirms the same thing that we found first time through. Even though the kids know what they're supposed to do, and they say that they're going to do it, when they're actually faced with the situation, most of them don't. So 69% in a 2014 study said that they did play despite having concussion symptoms, and 40% reported that the coach was not aware. In other words, they were keeping the symptoms from the coach. So it's an interesting dynamic where and again, I think this doesn't just apply to concussion, I think it applies to teenagers, but you can teach them and they can learn and they can tell you what they're supposed to do, but then when they're faced with that situation, they may not do what they're supposed to do. And the question becomes why? You know, why is it they're making that decision? And there's a lot of answers for that, but I think one answer is just the culture of sports. And we're supposed to be tough and we're supposed to play through pain, and just because you're a little dizzy and you're a little confused, if you can still get out there and run and kick, you should be in the game. And I think that culturally is the piece that we really have to work on, and I think we can all play a role in that. So in summary, you know, there is currently an expectation that every team physician is going to be knowledgeable in the evaluation and the management of concussion. So if you're going to put yourself out there, you have to know about this. You have to know about SCAT-3. You have to be prepared to administer SCAT-3 if you find someone in the situation. Aspects of this care are legislatively managed, and I think we've got pretty good evidence that the legislation has been effective at increasing awareness, especially among coaches and athletic trainers and doctors. It's not clear, I think it is clear the kids have been educated. It's not clear the kids are really responding to that education yet the way they should be, but it's a work in progress.
My name is Stan Herring, and it's really a pleasure to be here. I'd like to thank Dr. Harden for tackling this topic. Reflecting on the fact that an orthopedic surgeon introduces a pediatrician followed by a primary care doctor, followed by a physiatrist speaking to a room of orthopedic surgeons about brain injury. So that's where this has come. It's a medical and sociological problem. I'm fine with that, but what it does suggest then is you can't be casual or cavalier about this. And so what you've heard, if you're going to cover a team, you need to be prepared. If you're going to walk on the sideline, because there is, and I'm fine with that, there's an accountability around a brain injury. It's interesting because the great majority of these injuries, 80 to 95%, 85% or so, are better in 7 to 10 days. But they're common and they don't all get better, and if they don't get better, the consequences can be significant. So therein lies the responsibility for us. And listening to John go through the literature, some of Tom's work, some of our work from the Harvard Injury Prevention Center, let me see if I can put the cap on John's part of the talk. I was all involved with the last deadline and have been involved with all 50 states. I know all my state capitals, state birds, flowers, because I got to go testify. It's great to be in the state of Missouri, the Show Me State. And this is unusual to legislate a medical problem, but given the way that schools, school districts, and sports teams are rules-driven, an education policy alone was inconsistent and ineffective. And that's what drove the legislative piece, and the idea that this would be referred to as the Zachary Lystat Law, a very heroic family. Passing a law doesn't change your liability. Your liability exists the minute you assume a relationship with the patient. Passing a law does limit liability because it gives terms around an injury. And if you follow those terms or protocols, then the care is consistent. So it's been positive in that regard. And everything that John said about what we've learned and not learned, we understood that. So we knew that we needed the legislation to make a necessary foundation. We could not enact consistent change. We tried through policy modifications through school districts, and it was not as effective. And we have always said that these documents are living documents, and they will be modified as new knowledge becomes available and as the best metrics become available. We're already seeing states expand the laws they've passed, and we look forward to putting more science behind these laws. We're also spending a lot of time on the social sciences, looking to see what John says. We're trying to find the best way not only to communicate education, but to enact behavior change. And that's an interesting challenge which faces us. So it's great to hear this discussed in this room, and it's also great that the state of Washington led the way in this effort. I was asked to finish this conversation about something else which is interesting to me, which is the long-term effects of concussion. And it's gotten to the point now where I go to dinner parties and I'm the only person not talking about this. It's become such a sociological phenomenon. It's sort of interesting to me. And so I hear all kinds of things. You know, well, if I play sports, if my child or grandchild plays sports, then they're going to have depression as they get older. And there is some data, and I've kind of given you some summary data slides here, of surveys of retired professional athletes. that have some evidence of an association between the number of concussions recorded and the risk for depression. There's actually been very little research between concussion and suicide, and I will have you know that the published data demonstrates that the suicide rate in retired football players is lower than age-matched controls. So there's a tendency here to generalize this, so it's important to understand that these are, for the most part, retrospective surveys of retired professional athletes. There is no data on depression in amateur athletes or grade school or high school athletes in terms of long-term consequences, or what data exists does not show any relationship. There is information about mild cognitive impairment, that you're not quite as sharp as you used to be, and there are multiple studies, and I would say that probably the overall consensus, there's more studies that report an unfavorable change than others. So memory, processing speed, and in some cases, the symptom load has been able to correlate. So there is some suggestion that if you hit your head enough times, you may have mild cognitive impairment. It's just not good to hit your head unnecessarily. But once again, all of this data is in retired professional athletes. And I think this is important. Listen, no one's more concerned about brain injury than me. I was taking care of it before it was popular. So no one's more concerned about this, but I think it's very important to watch the suppositions that we make. And so listen, and when it comes to depression and mild cognitive impairment, should we be concerned? Yes. Should we proceed with caution? Yes. We need to take care to avoid generalization of data, and there's a desperate need for prospective longitudinal studies, no question about it. Those are ongoing now, but there's not an easy answer. Nothing wrong with being safe, but it's important to also be reasonable for two reasons. It's the right thing to do, and secondly, for all of you who have played, and there's a lot of athletes in this room, if you try to scare families and coaches and players away with this data and they know it's not true, they don't listen to you. So, appropriate concern, yes. And this really goes to this issue of CTE, chronic traumatic encephalopathy. I asked a group, I was speaking, I think San Diego the other day, and I asked the group what was the difference between Ebola and CTE. And the answer is not everybody gets Ebola, but apparently everyone gets CTE. That's all we hear about is, I'm going to play football, I'm going to have CTE. Listen, chronic traumatic encephalopathy is a degenerative brain disease. No question about it. And it's a post-mortem diagnosis. There's no test to look for this hyperphosphorylated tau deposition in living people. There's some discussion about options. And the symptoms are memory loss, depression, loss of impulse control, personality change, and progressive dementia. Not unique to, many dementias present this way. With CTE, it is a distinct tauopathy. The incidence cannot be known because it's a postmortem diagnosis, nor can the prevalence. So you cannot establish a cause and effect relationship from postmortem studies, right? This is basic epidemiology. You can have an association, but you can't do causation work based on postmortem work. So there's an association of these findings in some athletes who have dementia problems. Whether the tau causes it, whether the tau triggers something else, or whether tau is a marker for another disease is not yet known. So there's an association, but you have to be careful about it. You cannot make a causation interpretation. And so there is no question that these modern day cases of CTE, which are really different than dementia pugilistica, dementia pugilistica was boxers in their 70s and 80s, a lot of movement disorder and Parkinsonian features. There was not suicidality and as much dementia. It was different. So we're not exactly sure. I don't think it's exactly appropriate to compare the two. There's no question that further research needs to be done. But in that Zurich Consensus statement that Tom was referencing, I was there, and there was a lot of discussion about this. And we felt in Zurich that it was important to study it, but it was also equally important to address the fears of parents and athletes, and based on media pressure. We have young people afraid to play sports. There's not really any evidence linking youth sports to chronic traumatic encephalopathy. And if you don't play sports, there's other consequences of not playing sports. Ironically, if you're asked if it's too risky for your son or daughter to play sports, like soccer or football? The answer is yes, not because of the sport, but because of the risk of brain injury riding your bicycle to practice. I mean, the number one cause of brain fatality in young people are skateboards, bicycles, and motor vehicle accidents. So CTE is an issue. I'm worried about it. We're all worried about it. But the perspective piece is really important. And what the Institute of Medicine has said about this is whether repetitive head impacts and multiple concussions sustained in youth lead to long-term neurodegenerative disease, it remains unclear. And there is no question that additional research is being done. And once again, that we need to really proceed with caution here and talk about avoiding generalization of this data and looking at prospective longitudinal studies. And I think that this particular issue around the long-term consequences of brain injury associated with sport has really owned the headlines. We have taken steps. Listen, I think there's nothing wrong with removing unnecessary head contact from sport. As a matter of fact, we're doing a lot of things to do that. You can make a few choices. You can not play sport, or you can do things. I am a medical advisory chair for USA Football. And in USA Football, we have developed a heads-up tackling technique, which not only goes through tackle progression, but technique is taught to remove unnecessary head contact from play. We have required education of all coaches and parents on top of the laws with a concussion module along with football modules for competencies. And we've even moved to the point where each football team or league has a player safety coach to address John's question about, coaches. If you tell a coach in 2014 that a young athlete is concussed, they will look at them. What we've learned is they're also coaching. So we've made a move to a point, an individual whose only job is to look for injury, not just brain injury, but injury on the sideline. And we're studying that now to see if putting the right personnel in place may make a difference in behavior change around the injury. John's point, and the point from our work too in the Injury Prevention Center, of kids not reporting is a challenging one because the symptoms are so broad that if you ask them, that's what we did in that anonymous survey, a lot of kids have these sort of symptoms. The work remains for us, though, is to probably ratchet down the diagnosis of what is a concussion so we can really understand the epidemiology, recovery, and risk stratification for these kids. But to be perfectly clear about this, bad things can happen if you let young people play concussed. They're rare, but they can be catastrophic. And John started with the story about Zach. This is a Leistet family, Zach, Victor, and Mercedes. They have become an integral part of our concussion movement. We speak publicly together, and the Leistets have made it their concern that this preventable brain injury never happen again. The key here, and it's what Dr. Harden said, it's not the first blow. It's playing symptomatic with the first blow that can cause the rare but terrible catastrophic events. If you just take them out, then they'll be fine. This is what the focus of the law is. So the Leistets remain involved. This weekend, the commissioner of the NFL came to honor the Leistet family at the Brain Injury Gala of Washington, because all 50 states did pass laws. And Zach stood up and gave a nice speech and thanked the NFL, and he said, I just don't want this to happen to any other kid. And if they can, this is an amazing family whose purpose is greater than their challenges, and their challenges are frankly unbelievable. And I said that night, if they can do that, then I think that all of us as healthcare providers, if you see a young person who's potentially concussed, I think that we have the responsibility and the duty to consider removing them from practice or play to prevent a preventable tragedy, once again, in the context of an injury which usually has a favorable prognosis. And I tried to, a little time for question and answers, so listen, I wanted to make sure there was some Q&A time. It's a pleasure to speak with my colleagues, and thank you.
My question's for John, Tom, and Stan. It seems that the highest rate of concussion is in girls soccer and in lacrosse. And if that's true, where do we sit with trying to invent a way to have girls wear helmets? And is helmets an answer?
What Dr. Wagner said, the rate, it turns out that the rate of diagnosed concussion or suspected concussion in a sport where girls and boys play by the same set of rules. Soccer in high school, or basketball, lacrosse, and as you know, is a non-contact sport for girls. When there's rules that are the same for both genders, the reported rate in girls is consistently higher. The mechanism of injury is also often different. The higher reporting rate, this gender issue is still debated. It may simply be that, here's a news flash, girls are smarter than boys, and they actually tell you. And it may be that there are some gender differences. Once again, in most sports, girls or boys, the concussion rate, with high concussion rate, kids do get better. The equipment issue that Dr. Wagner has raised is, so the purpose of a helmet in football, okay, a rigid plastic helmet, was because in the early 1900s, 21 collegiate athletes died playing football. What killed them? Depressed skull fractures. That's what killed them. That's a bad injury, as you know. That that was where the NCAA was started for player safety. Since the onset of rigid plastic helmets in football, at least in the NFL, I'm not sure, but college did, there hasn't been one depressed skull fracture. There hasn't been one skull fracture at all. So they work. They work exactly for what they were designed to do. The irony, of course, is if you give someone a rigid plastic helmet, you've given them a weapon. So the concussion rate goes up, the severe brain injury due to skull fracture goes down. Helmets were never designed to prevent concussion. They're being held to that standard now. Now, one of my disclosures was I'm working with the Center for Commercialization here at the university and the head of mechanical engineering, and well, those are interesting meetings, like, you know, where'd the numbers go? And that we're looking at polymers and to look at decreasing force around concussion. I think that, Ted, I think we can effectively engineer helmets that will decrease linear and angular accelerations. The challenge so far is that looking at those numbers in other systems, there has not been a correlation between clinical concussion. So there's a lot of steps in designing a piece of equipment that will decrease concussion because we don't exactly know why people get concussed. There's clearly an individual predilection. I think that the helmet design will continue, protective equipment will continue, but right now I would not proffer that there's an equipment solution for brain injury, and unfortunately, Ted, if you put helmets on soccer players, they may become more aggressive, not less, so we'll see what happens. But that's a burning issue. Other questions I should let unless I didn't cover that, you can ask him.
There was an interesting case study reported within the last 6 months of a young man, maybe late 20s or 30s, that had amyotrophic lateral sclerosis and had played a lot of soccer and had started heading a soccer ball at about age 3 was the story. And so, you know, when I look at my daughter play soccer and I see how the ball moves and how they head, 9 out of 10 headers up to age 12 don't go where the kids intend and can often be quite a bump on the head. And so I was wondering, you know, what do you recommend to coaches that are trying to teach a game where there's, you know, an implied contact with the head where it may or may not be safe?
Yeah, I think that's a really interesting question, and I'm on the medical advisory board for Seattle United, and we've put together a policy about what we recommend our coaches do in terms of teaching heading now. There aren't hard rules yet. Some people have proposed hard rules about set ages at which point you can and can't head. The more data from that study was that actually about 30% of the concussions that we saw, or the concussion symptom reports that we had, the players were reporting that they were trying to head the ball. They didn't report that they had any other contact, but as you get to older levels, there's data that suggests that heading alone probably doesn't cause concussion. So that it may be different in kids. It may really be that the active heading does carry a little more risk in kids than it does in adults. But there also is evidence that if you head a ball correctly, you actually are less likely to sustain an injury than if you head it incorrectly, and that's indirect results from biomechanics. So I think you can make an argument, and this is what our recommendation is at Seattle United, is that it is appropriate to teach heading because it's part of the game, but you want people to head when they're younger in a controlled situation, tossing a soft ball, having it not be overinflated, making sure it's not leather. No one has leather soccer balls anymore, but they actually weigh more and they can sustain injury. So, you know, and making sure that they're heading correctly, that they're using their body correctly, that they're absorbing the force, that they're hitting the right part of their head. And then as they get older, then you can progress more into trying to head in game situations, not punts that are up in the lights necessarily right away, not driven corner kicks, and then that sort of, then you progress with that. And I think the most important thing too is that kids tend to start to head when they're ready to head. When they're not doing it well and they do it badly, it hurts and they don't want to do it again. And so our biggest drive with the coaches is if you have a kid that is coming across on a corner kick and ducks, let them duck. Don't sit there and scream at a 10-year-old, get your head on it, because they're not ready. That's why they're ducking. As they start to feel better about it and they start to feel more confident, they will start then to go for that ball. And so, again, we don't know the answer, but I think that's a reasonable recommendation where we are right now.
I'd be interested in your comments on the role of baselines in professional athletes, because in rugby league, which probably has 3 times the number of contacts and collisions of any other sport, once they introduced baseline testing, we didn't know if they were getting dumber or smarter because their baseline got worse, but that was probably because they told each other they need to fudge the test so that they can get back soon. So what do you see as the role of baseline, and are they getting dumber or smarter?
The NFL has now mandated baseline testing, not just neuropsychological testing, which is also mandated, but the physical exam testing. So the SCAT-3 form is recorded at baseline. I think there's some value there. It's been my experience if they can't repeat the months of the year backwards before they're concussed, they're unlikely to be able to do it after. Tom Jinguji and others, we've published too that people have a lot of baseline symptoms. About 18% of people have headache at baseline, and about 17% have cervical spine pain. And so if you know what they are like before they're concussed, and when they have persistent symptoms after, you can sort that out. Bruce, you are right. It's interesting. The effort put into baseline testing may not be the same as the effort put into post-injury testing, because post-injury they want to get back. Rather, not even just intentionally dumbing the test down, but just effort. So I do think it's important to know your athlete. There is variability in the testing. There have been some norms established. Baseline neuropsychological testing, people think there's a computerized concussion test. Interpretation of that test data is also very skill specific. We do both baseline and paper and pencil testing, but it's interpreted in a neuropsychological context. So I think it's better to know your athlete pre-injury. You've taken care of rugby players. If you know them, you know when they're concussed. Do I think that there's limitations in baseline testing? Yes, I think it's better if it's done by those who know the athlete. I do think that if interpreted correctly, it has value. I have seen special forces soldiers who come in with brain injury and they have tattooed the 5 words they think they're supposed to remember on their forearm because they want to go back. You think athletes want to go back. So I see them looking at their form. I give them a different list of words, and then all kinds of chaos breaks out. So I think the tools are only as good as the carpenter. In your hands, knowing your athletes, with your experience in brain injury, do I think that care is improved with baseline testing? Yes. Do I think it's as simple as saying, get the test before and after, and we'll be better? I think there's worry there because you have to, it's like anything else in medicine, they have to be interpreted contextually. I do think there's a move, though, in professional sports, and I'm sure rugby will do the same thing. We've been talking to the IRB. I'm sure there's going to be a move to do this.
And the one other thing I would add to that, too, is that we don't yet have a test to diagnose concussion, right, and an objective test. And when we do, that will be very helpful, and it will be a game changer. But right now, there is no better way to really assess that someone is different than to know them before. And I think that's the critical baseline test. The critical baseline test is, have you met this athlete before? Do you know them? Do you know what they're like? And it's important to understand that, because you can't accomplish that by taking someone who's sort of a declared expert and dropping them into a situation on game day and expect them to be able to make a better assessment than, frankly, a parent. And in high school, that's not a bad idea. If you really don't know what's going on, ask the parents. Get the parents involved. Is this your son or daughter or not? And because you really need to, that's really the best way to make this determination in this day and age.
Stan, do you really think that a helmet can be redesigned to account for the tremendous increase in the size of the athlete, the strength of the athlete? The brain can't get stronger. The body can get twice as heavy. The muscles can get twice as big. But inertia is inertia. Do you really think that helmets can be designed to overcome that change in the human anatomy?
It's a great question. I've never been one to proffer a piece of equipment as the answer to concussion. Vince, it goes a little bit to what John said. We don't exactly know what a concussion means. There are people who can take huge blows and they're fine, and people who take glancing blows and they're symptomatic for weeks on end. And concussions are so unique. I always say if you've seen one concussion, you've seen one concussion. Interestingly, while the reported rate of concussion has gone up, it's probably because of reporting bias. And actually the rate of serious brain injury, I think, as Emily said in her talk, or Tom did, has really not changed. I don't know. There's a lot of factors here. I think that we can effectively design equipment that dissipates force better, and it may be that angular acceleration is a big deal to certain parts of the brain. I'm watching that work being done now. There's a lot of money being spent on that by the DoD and others. There's the $60 million NFL GE Challenge Grant. So there's a lot of interest in trying to dissipate those forces. I'm always very careful, including my work with the Center for Commercialization here, to say all you can do now is design a piece of equipment that can effectively dissipate force. Then you have to see if it makes any clinical difference whatsoever. So I'm not sitting around at home waiting for the piece of equipment that's going to make the concussion issue go away. I think it's going to be much more complex. I think this is going to be a risk stratification issue that will go to number, severity, frequency of blows. There's got to be a genetic component to this and other issues. We already know, Vince, that kids with ADD and ADHD recover more slowly. We know that people with migraine headache disorders recover more slowly. So there's clearly other issues here. Will the equipment be part of it? I think so, but I'm not holding out hope that it's the answer. Thanks, Howard. Thanks.
Group photo.